morning from California. Today, what we're going to talk about is common radiographic incidental findings with cone-beam CT and what to do about them. And I'm Dr. Heidi Coltfarber. I'm an adjunct assistant professor at UNC Chapel Hill, and I'm an oral and maxillofacial radiologist with a private radiology practice. So we want to talk about some of the common incidental findings that we may see. So our objectives for today are really talking about the prevalence of incidental findings, what anatomical regions we might find these findings in, and how do we describe them, and more importantly, what do we do with them? So first of all, we want to look back at the research, and there have been several research papers over the years trying to categorize what type of incidental findings we have and what locations we might find them in. And so I've given a sampling here of some of the various research. Now, this particular one was in a young population, average age of 14 years, and this is an orthodontic population. And what we found with the younger population is we see the majority of incidental findings are within the nasopharyngeal airway space. Followed by the paranasal sinuses, dental alveolar, TMJ, and surrounding hard tissues, and then finally the cervical vertebra. But the majority in our younger population is going to be something with the airway space. Maybe we have a constricted airway space due to enlarged tonsils or that sort of thing. And so that's our younger population. This particular research article was in 2017, and it looked at a much more diverse age-related population. And so in this particular research article, the mean age was 37, but you can see it's plus or minus 18.3. So in reality, it looked at people, I believe, from age 8 up to 91. So quite a diversity as far as the age range. And when this one, they found the majority of incidental findings were in the dental alveolar region, about 27% of our incidental findings, followed by the airway space. Soft tissue calcifications, they found that the soft tissue calcifications increase with the age of the patient, which of course makes sense. This was then followed by the temporomandibular joint, so about 16% of findings were discovered within the temporomandibular joint region, followed by items found within the bone, lesions of the jaws, and other types of pathology. So when we're looking at our cone-beam CTs, we know that about 90% of cone-beam CTs, actually 92%, have some type of incidental findings. And on average, we find about 3.73 findings per exam. Excuse me. Of those findings, we see that about 43% of findings, 44%, require no treatment. And that's great. That's great for the patient. It's just an incidental finding we don't have to worry about. About 28% or 29% of findings need some type of monitoring. And so that's additional imaging. We have to re-image the patient at a certain time. Perhaps we're looking to see if there's some type of a growth potential with whatever it is we're looking at to let us know if we have a pathology going on. And another about 28% of findings do need a referral or be sent to other professionals. When we look at all of the research articles looking at incidental findings across the board, we tend to see on average 3 incidental findings per scan, and a wide variety of differences in what is actionable based on the research article, but overall an average of 30% of our findings are actionable, which is what we saw in the previous research article as well. So what kind of action would this be? Treatment, maybe other diagnostic tests. We want to actively monitor these patients, or a referral. So the areas that we're going to talk about today are going to be dental alveolar, maxillomandible. We're going to talk about the temporomandibular joints, paranasal sinuses, airway, and we're going to just briefly brush into soft tissues because of the time constraints today. So one of the number one things, of course, that we're going to see as an incidental finding with combeam CT is periapical lesions. And in this particular case, we can see we have not only a periapical lesion, but we have a mucosal thickening within the sinus, and that is odontogenic in origin. In fact, we can see superior displacement of that inferior cortical border of the maxillary sinus, and we do have perforation as well, and that leads to our mucositis that we see. What's going to happen, of course, with this, we realize that there's a lesion going on, and this needs root canal treatment or extraction. Now, many times based on our 2D imaging, we didn't see apical lesions as easily as we can with combeam CT. And why is that? Well, that's because with combeam CT, we're able to see between the cortical borders. When we're looking at a 2D image, we have so much superimpositions that it makes it difficult for us to see that actual lesion unless the buccal or lingual cortical borders are breached. And so we can definitely see with our CBCT many more periapical lesions than we could with 2D. Here's another one. We can see we have a nice periapical lesion. Now this one we do have erosion of the palatal cortical bone. We also have erosion of the inferior cortical border of the sinus. And again, we have our localized mucosal thickening that is odontogenic in origin. We can see a whole host of other things besides just our periapical lesions, although obviously endodontic applications are a huge part of what we see with CBCT. We can see this particular case, there's an unknown dens and dente. And if we look close, we can also see that we have a nice diffuse hypodensity or radiolucency around the apex of that tooth as a result of a oral connection through that dens and dentate. And of course, this is going to require root canal treatment. Many times when we're looking at particular cases, we may not be sure if we have external versus internal root resorption based on our 2D imaging. We can take multiple images trying to see if that has moved, but with combeam CT, it makes it much easier for us to determine what it is that we're looking at. And so in this particular case, we can see not only do we have a large draining fistulous tract, but it almost looks like something took a bite out of that tooth. We've got this granular hypodensity on the distal aspect of the tooth. Lets us know that yes, we do have external root resorption along with that draining fistulous tract. Now, sometimes our external root resorption is so large that it even gets picked up in our skull views or our volume reconstructions. And we can see in this particular case, the external root resorption is plainly observed. And so this is great for patient education. We can let the patient know exactly what's going on with their tooth, where it's located. As many times the patients aren't even aware that they may have this going on. And this was the CBCT that is correlated with our volumetric reconstruction there. So obviously these teeth have a poor prognosis and most likely is going to require extraction. And again, we can see the difference between our external versus our internal root resorption. And so here we have cases of internal root resorption. And what we can see, particularly this case, we have a granular hypodensity within that tooth, and we have an enlarged pulp chamber and canal. And that lets us know that yes, we do have internal root resorption. We can definitely see that we've got some severely dilacerated roots, so this could be a very complicated case. This was another case of a young patient who showed up with pain on this particular tooth. You can see, yes, we do have slight widening of the apical periodontal ligament space. And when we're looking more closely, we can see we have a fusiform enlargement of the canal. Now, it could be variation of normal, could be that we have something going on. When we're looking at our CBCTs, it always helps to compare the contralateral side. And so we can see in our axial sections that the canal was enlarged when compared to the other side. Now, that could be a variation of normal, or it could tell us that we have something going on. Really nice with CBCT, we can go ahead and measure. And so, yes, according to our measurements, we do have enlargement of the canal. It fits with our picture of slight widening of the apical periodontal ligament space. And so we can deduce, yes, we do have internal root resorption, very early internal root resorption on this patient. We can go ahead and take care of it at this stage, which really helps our patient out. So these cases of internal root resorption, it does depend on the degree, obviously, of root resorption, whether we're going to do root canal treatment to try to stop this process or extraction. As another case where we have a large radicular cyst or dental granuloma. So the first thing when we see this hypodensity, we want to figure out where is this coming from. If we're going to compare it as far as the density goes, it's actually isodense to soft tissues. But if we were to compare it with the density of bone, then it's hypodense to the density of bone. And so understanding where this particular entity is coming from is very important in deciding if this is something that's coming from the sinus or if it's actually coming from the dental alveolar bone. Lets us know if this is odontogenic in origin. And what we can see is we have a nice inferior cortical border of the sinus. We can see that it's being displaced superiorly. And so that lets us know that this is coming from the alveolar bone, and we're looking at an odontogenic source for this. The next thing we want to do is figure out the epicenter of that. So where is our epicenter? Well, it looks like it has to do with our root canal treated tooth. And so we want to rule out a non-healing root canal treated tooth. Perhaps we have a missed canal, or perhaps we have a root fracture. So we definitely want to look at the epicenter of that. We might also want to do vitality testing on the molar just in front, just to be careful. Of course, this is going to probably result in root canal treatment for this particular tooth, or even extraction, depending on what we find as we go through the CBCT. So the things that we will look for if we have a non-healing root canal treated tooth, we want to evaluate the canals. Perhaps there is an unfilled canal, as was the case with these. So in this particular case, you can see that our distal buccal root, there's no endodontic filling within that canal. This is another case in which our mesial buccal root had no endodontic filling within it. And so we can see we've got not only a missed MB2 canal, but we also have missed MB1 canal. We can also see, obviously in our axial sections, very easy to be able to see those unfilled canals. Now, usually it's not quite this blatant. Obviously, these are entire canals that were missed, and these will require retreatment. But sometimes we are just looking for that elusive MB2 canal. And so in this particular case, that's exactly what was missed. Here we had our non-healing root canal treated tooth. We can see that we have a draining fistulous tract on the buccal aspect of it. And when we look in our axial sections, we have evidence of an unfilled MB2 canal. And this is usually more typical of what we see with these particular teeth that are not healing. So this will require root canal retreatment if it is possible, if we don't have too much bone loss. And that's what happened with this particular case, was retreatment. Root fractures is the other thing that we look for, especially with our non-healing root canal treated teeth. Now, these can be difficult to see due to beam hardening artifacts that we have with our CBCTs. So if the patient's already had root canal treatment, sometimes it can be difficult to see. We also know that that fracture must be displaced more than our resolution of that particular unit. So if, for instance, that particular image was taken at 0.1 millimeters, the fracture has to be displaced larger than that for us to be able to see it in our images. And so this particular one was a case where we had a non-healing root canal treated tooth. Obviously, we have mucosal thickening that's odontogenic in origin, and we'll do fine sagittal slices and very fine coronal slices looking for an actual fracture line. Now, again, we have beam hardening artifacts. And so if you see a linear hypodensity, but it follows the line of your canals and your endodontic filling, then we're more likely to say, no, I think we're looking at a beam hardening artifact. But in this particular case, we could see that we do have a vertical fracture line, and it does not follow the canal. So we know, yes, we do have a vertical root fracture that's causing the issues for this patient. Now, obviously, a tooth such as this, you can obviously see the huge displacement. You're not going to miss that very likely. But this was an interesting case in a patient that was completely asymptomatic, and yet we have a nice root fracture. Now, obviously, these patients will come in with a cracked tooth syndrome. Most patients will have some type of twinges and feeling when they're biting down, so we've got some percussion sensitivity. And obviously, all of these teeth here are going to need to be extracted. They have a very poor prognosis. We can also see supernumerary teeth. We have mesiodens. It's very, very common to see that. And they tend to like to swim upstream. What we can see here is we do have some external resorptive process going on that is not rare when we have a long-standing impacted tooth. So very common to see that we're starting to have a resorptive process. And usually that does let us know once this tooth starts to resorb that it's ankylosed. And so usually these are going to stay put, maybe no treatment with that. Now, if we have multiple supernumeraries, we start to worry about maybe a syndrome such as Gardner syndrome or cleidocranial dysplasia. We're going to have concrescence. So this is fusion of the cementum. And so we have fused these two teeth essentially together. What you're going to see is that the periodontal ligament space now goes completely around both teeth. Very, very good to know this before you do an extraction. When I was a general dentist in private practice, one of the individuals in our practice was trying to do serial extractions in a young orthodontic patient. And so they were extracting the first premolars. And I noticed as I walked past the room about an hour or so later, he's still over there working really hard, trying to get this tooth out. And all of a sudden, two teeth popped out. So it was like two for the price of one day, which not really what you want to have happen. But so what had happened is there's concrescence. And based on the 2D imaging, that wasn't observed. And so the patient was not treatment planned accordingly. With Chromium CT, you can easily see that we do have fusion of that cementum. And so we can treatment plan that appropriately. And of course, if you're going to do extractions for orthodontic purposes, that may, of course, decide which teeth you extract, or if you do extract at all. Anastosis, these are very, very common. This is probably the number one thing that we're sent in my private radiology practice. This is known by many different names. So idiopathic osteosclerosis or dense bone island. And what we can see is we have a hyperdensity that is isodense to cortical bone. It is continuous with your cortical borders. You'll note that we do not have any expansion, and we really have no effect on the surrounding structures. The mandibular canal is intact. The periodontal ligament spaces around the teeth are intact. So we want to make sure about that. We don't want something that is fused to a tooth root. So we just want to look for that periodontal ligament space. We know that basically this is just dense cortical bone. Now, anastoses are so common, you see it all throughout the skeletal bones. It's not just specific to the jaws. Now, the posterior mandible is the most common, but it can be anywhere. And this is a do not touch lesion, or entity, I should say, because it's really not a lesion. But we do get sent this all the time. Doctors are very concerned. They want to do a biopsy on this, and really we don't need to do anything because it's just dense cortical bone. Now, this particular entity, when it's in the more immature stage, will look more hypodense, but it'll increase in density over that lifetime of the patient. So here's another couple of cases. Now, what we can see is rarely it can cause apical root resorption, but you can always see the periodontal ligament space around that tooth. So it's not fused to the tooth. which is a big difference between an anostosis versus benign cementoblastoma. We want to make sure it's not fused to the tooth. We want to be able to see the periodontal ligament space, but it can rarely cause some apical root resorption. We also see enlarged marrow spaces or focal osteoporotic bone marrow defects. And we usually will see this in the region of the anterior mandible. In fact, we just had a case last week that was sent in where an oral surgeon was very concerned that there might be a lesion in the anterior region. And really what we're just looking at is enlarged marrow spaces. We know this is a region that happens. If we're looking closely, we can still see we do have a fine internal trabecular pattern to it. The other thing that you want to look at is your cortical border. If we have thinning of a cortical border, then we know there's something there. But if there's no thinning of the cortical border, it is intact, there is no expansion, well, it lets us know we do have an enlarged marrow space. Again, if you're ever in doubt, you can always send that to an oral maxillofacial radiologist like myself, and we're more than happy to help you with that. Osteoporotic changes, yes, we do see those. We know that about 5% of the population is going to have osteoporotic changes, meaning that you're going to have thinning and pitting of cortical borders. You're going to have a generalized granular appearance to the bone. And of course, we know that we have very poor bone quality in these individuals, which will affect implant placement. So it's important to be able to visualize that and identify it. The other thing is it may make it really difficult to evaluate the mandibular canal and to be able to trace that for implant planning purposes. We can also have various iatrogenic problems as well. And so in radiology, we do see the good, the bad, and the ugly. And so we just state things very factually. But clearly we can see that a pin has been placed here that extends through the tooth and into the bone. And so we really just want to alert the patient that there is a problem there, and we can work to resolve that problem. And so that will be what the general dentist will be doing with that particular case. As far as radiology, we'll just state the facts. All right, let's look at the maxilla. If you're coming down through your axial sections, sometimes we see an enlargement of our incisive canal. We can measure that. If it is larger than 6 millimeters in diameter, it could let us know that we have a cystic process. So what we'll want to do is go ahead and look in our sagittal sections. And if it looks like we have stuck a water balloon or a grape within the canal, it lets us know, yes, we do have a cystic process. Now, occasionally, the patient doesn't have a lot of palatal cortical bone. And so that can make it a little bit trickier for us. In that case, we're going to go ahead and reevaluate that particular patient, maybe 6 to 12 months. Our nasopalatine duct cysts are very, very slow growing. And so it'll take time for us to be able to see a growth potential that could alert us to the fact that there is a cystic process. And so usually we'll recommend reevaluation of a case if it is uncertain or inconclusive, as we have in this case. Cheek augmentation. Sometimes our patients go and have various beauty treatments and they don't want us to know that. And so they may not let us know that they've had some type of dermal filler, but we can see it radiographically. And so what you usually will start to see is we have these lobular hyperdensities within the soft tissues of the cheek. Interestingly enough, we've had plastic surgeons come to our Radiology Academy meetings, and they do want to let us know that, yes, while we see them and we know what they are, you may not want to let the patient know that they're asymmetric, because that's the reason they had plastic surgery or they had some type of dermal filler placed in the first place. So that's kind of always fun to find, and usually the patients don't necessarily share that. We see a whole host of neurovascular canals. Very, very common to be able to see those in 3D, and we weren't used to seeing them before in the 2D. So our anterior superior alveolar neurovascular canal can sometimes be quite large. And usually this comes down inferiorly in about the canine and lateral incisor region, but we know that anatomy has not always read our textbooks, and so there's variation in that. So here we see it extending inferiorly in the region of the anterior maxillary incisor and the lateral incisor. But we can clearly see that we have nicely intact cortical borders. It's very linear, and we have a nice linear hypodensity to follow. So that lets us know that we do have a neurovascular canal. And again, no treatment with that. We can also see it extending along the lateral and inferior aspect of the sinus. We'll see the posterior superior alveolar neurovascular canal and associated branches. We want to be able to identify that if we're planning to do a sinus lift and bone graft, because this can be a source of post-op complications. It can also cause increased bleeding into the surgical site if, for whatever reason, that neurovascular canal is clipped. So we want to know where it is, and we want to be able to avoid that. This was a very interesting case. This particular patient case was sent to us. This is a 60-plus-year-old female, and it was sent to us from an endodontist, and they were concerned about which tooth they need to work on. Which tooth should they treat? Should they treat tooth number 7 endodontically? Maybe they need to retreat number 8. Now, 9 was avulsed years ago, and of course, this is tooth number 10 over here. But on the 2D image, it looks like we have a apical hypodensity. When we look at it in all 3 planes with our CBCT, we can see we have a large bony defect, and this is what is being transferred across and what's showing up in that 2D image. And we can see easily that we do have an undiagnosed cleft palate in this particular patient case. So, interesting case, we sent it back as an undiagnosed cleft palate, and the doctor ended up calling us back and saying, well, the patient says that she doesn't have it. No, doesn't have what? Well, she doesn't have a cleft palate. And again, this is what I love about radiology. It's the facts, ma'am. So I've never seen anybody who actually wanted to have endodontic treatment, but clearly she did. She'd rather have that evidently than her cleft palate. So we find very interesting things when we're going through our CBCTs. Let's talk a little bit about the mandible. We can see various salivary gland depressions. We know that we have Staphny bone defects. They can be in about 5 different areas within the jaws, but anywhere that you have salivary tissue, you can have a bony defect. And so here we have one in the anterior region, which is a little bit more rare than the ones that we see in the submandibular gland region. But this is our sublingual salivary gland. How do I know that we're looking at a Staphny bone defect? Well, what we can see is we have intact cortical borders. And so clearly what's happening is we have a peripheral entity that's pushing in on the bone. It's slow growing because it's slowly remodeling that bone. And that lets us know that, yes, we do have the classic signs of a Staphny bone defect. Now, these do not have an epithelial lining. If we look at them with CT, they have fatty and glandular tissues. And there's a variety of theories behind why this might happen. But the key is we have that intact lingual cortical bone. It is in the region that we have salivary tissues. And really no treatment is needed in these cases. Now, this is the more classic one that we think of, our submandibular salivary gland depression or Staphny bone defect, which you'll notice with this again, thickly corticated borders. It's taking the time to remodel. And again, we have a peripheral entity that's pushing in on the bone. We have otherwise intact cortical borders. This is, as you'll notice, it is below the mandibular canal. So if it's below the mandibular canal, it's not likely to be odontogenic in origin. And we can also see it from the tail of the parotid. So this is along the lingual aspect of the ascending ramus, or the neck of the condyle. Now, sometimes we're concerned about maybe weakening of the condylar neck, particularly in this region. This is something we can easily monitor, but again, there's really no treatment necessary for it. It's just that salivary gland tissue that's kind of pushing in on the bone. We can see various fibroosseous entities. We can see this all throughout the maxilla and the mandible, very, very common. But one of the places that we may not learn about in dental school is the angle of the mandible. Now, again, this is going to be below the mandibular canal. So again, we know it's not odontogenic in origin. And if we're trying to say, well, maybe there's something there, maybe there's not, it's maybe not corticated, but we do see we have a granular hypodense appearance. Maybe it looks a little bit cotton wool or ground glass. And we look in our coronal sections, you see, yeah, we do have thinning of the otherwise intact cortical borders. So there's some remodeling of those cortical borders. Well, this happens to be a classic location for a benign fibroosseous entity. If we're concerned about it and we're not sure what we think it is, we can always reevaluate this in 3 to 6 months to rule out a growth potential for it. We want to rule out a more aggressive entity, such as an ossifying fibroma. But many of these cases will stay exactly the same. For whatever reason, we tend to see benign fibroosseous entities at the angle of the mandible. We'd also see variations in our canals. We talked about those neurovascular canals. Very common to see that. We might have bifurcation of the canal, trifurcation of the canal. And the same thing, of course, with our mental foramen. We might have 1 foramina, 2 foramina. These are all variations of normal. But we want to make sure that we're tracing these and evaluating these before placing implants. Now, just as we could see cheek augmentation, we can also see chin augmentation procedures. And so if we're looking at our axial section, we have a hyperdensity. It's hyperdense as compared to the soft tissues. We can also see it looks like we've got cortical bone. In fact, it looks like we have bone that's actually growing around this particular entity. And these are some chin augmentation implants. They are designed to be more porous so the bone can kind of grow around and integrate into it. But we can also see some erosions occasionally in the regular bone due to our augmentation implants in the chin area. So just be able to identify it, know what that is. Again, sometimes patients don't want to share that information with us. We can have variations in the lingual canal. So here we can see that we've got 1 lingual canal and another lingual canal. Very, very common in this area. Might have 1, might have 2, might have 3. Again, our neurovascular canals may not have always read our textbooks, so they can pretty much do what they want. All variation of normal and nothing to worry about. Here we have a lingual submental canal. So this is coming in along the lingual aspect of the mandible. And again, how do I know that's a canal and not a fracture? Well, we have nicely corticated borders and a nice linear hypodensity, where a fracture is more likely to be more jagged, and we're not going to see that with nicely corticated borders on either side. Now, of course, we can also see pathology. So here we have an odontoma. This is an older female, I believe she was 82. What are we going to do with a compound odontoma in this area? Probably nothing at her age. But if it's a younger individual, we'll want to go ahead and remove that. But we can clearly see what looks like multiple little teeth. Now, how do I know it's not just supernumeraries? Well, it's in the same cystic space. And so that alerts us to the fact that we do have a compound odontoma. Now we can look at the temporomandibular joints as well. So this is a huge area of research, especially with coming CT. And my PhD was in the area of the temporomandibular joints. And we use something called the Research Diagnostic Criteria for TMD. And this is a cohort across the world that's come together and put some guidelines together for us to be able to evaluate condyles or the temporomandibular joint. And there's actually 11 osseous guidelines, and then it's funneled down into 3 different diagnoses. No osteoarthritic changes. Maybe it's indeterminate for osteoarthritic changes. So for instance, if you have articular surface flattening, that could be adaptive remodeling, which is really indeterminate for osteoarthritic changes. If we have patchy subcortical sclerosis, that may not let us know that we do in fact have osteoarthritic changes. So it's more of an indeterminate thing. We can also have those anastoses I talked about within the condylar region. And so it could be something like that. But when we start to see subcortical pseudocysts, surface erosions, anterior osteophytes, or a generalized bony sclerosis, it lets us know that yes, in fact, we do have osteoarthritic changes. And so let's talk about this just a little bit. And I want to discuss just a little bit of the anatomy, just a quick review. We're talking about the glenoid fossa region. What you can see is nice, thin cortical borders. That means it's nice and healthy. With inflammation, we get thickening and sclerosis of cortical borders. And so that'd be something to look for if we're concerned about inflammation. But here we have a healthy glenoid fossa region. The other thing we want to look at is the cortical borders of the condyle. Now, it is important to note that these cortical borders are not fully ossified until individuals between the ages of 21 to 22 years of age. And so, if, for example, you have imaged an 18-year-old and you don't see the cortical border, it does not mean it's not there. It means it's not fully ossified, and we can't see that in our images. And so, definitely something to think about when we're looking at our images. So a couple of things that we'll note. Here we have a nice normal condylar head, nice intact cortical borders. And here we have what looks like a notch at the superior aspect of the condylar head, but you'll notice the cortical borders are still intact. And this is our bifid condyle, which is a variation of normal. And then we might start to see flattening, tend to see it at the superior lateral pole first, but you'll notice we still have some intact cortical borders. They're not, there's not erosion with that. And so this is really indeterminate for osteoarthritic changes, lets us know we have adaptive changes going on within that temporomandibular joint. But then when we start to see actual pitting in that cortical border, that's when we know that we have erosions. And this is usually the earliest sign that we have osteoarthritic changes. Here again, we're starting to get some erosive changes. Once we start to see osteophytes, this is our anterior bony apposition. We tend to think of it on the anterior, but when it becomes severe, we can also see it in the medial or lateral aspect. Then we know for sure we do have osteoarthritic changes. Here again, we can see a medial osteophyte. So we know we do have those osteoarthritic changes. We can also, with this case, see generalized bony sclerosis. Here we have another case with generalized bony sclerosis. Looks like we have a cyst, and this is our subchondral pseudocyst. It's a breakdown of the bone in response to that inflammation. It is not epithelial lined, and these can spontaneously heal over time. As one of our professors used to tell us, you might treat this patient for TMJD, and the pseudocyst will heal in 2 years. Or you may do nothing with that individual, and that pseudocyst will go ahead and spontaneously heal in 2 years. So what does that tell us? This is very multifactorial. We don't always know what causes these things, and it's not always associated with patients' symptoms. All right, paranasal sinuses. Of course, this is something that we commonly see with our CBCTs. We see our nice air-filled cavities. We know that these will pneumatize over the lifetime of the patient. And so occasionally it doesn't pneumatize down and we'll end up with a hypoplastic sinus. But we definitely see lots of things in the sinuses. What we're concerned about is the sinus ostium, the opening. We don't want to block that drainage or the patient could end up having issues. In fact, we're worried about our whole osteomeatal complex that we have here. So if the patient has mucosal thickening and we decide to do a sinus lift and bone graft, we don't want to pick that mucosal thickening up and block the sinus ostium, because then the sinus can start to act like a pathological cavity in and of itself. And so it'd be important to send those patients to ENT before they have any type of surgical procedure. Now, it's common to see things in the sinus. Mucosal thickening of 1 to 3 millimeters is considered within normal limits, and we may not be too concerned about it. We can also see that if you have any type of post-surgical appearance, we'll have enlargement of that whole osteomeatal complex, because they're trying to open up that drainage pathway for the patient. In this case, we also have pneumatization of the sinus. Again, that is a variation of normal. You can see various polyps within the sinuses as well, so that's very common to see. And we really don't need to do a lot with them. It lets us know that we have some type of an allergic sinusitis. We want to look at the cortical borders, make sure that they're nicely intact, and make sure it's not something that's causing an issue for that patient. And we can see acute versus chronic sinusitis. With acute sinusitis, you'll notice we don't have any thickening or sclerosis of cortical borders, and we have air bubbles within the sinus. So it lets us know that we have some type of activity, active secretions. In fact, it almost looks like we have waves within the sinus. So this is an acute sinusitis. We do not need to refer this necessarily to ENT. This usually can be an allergic rhinosinusitis or a viral or bacterial rhinosinusitis. Now, if the patient complains about it for longer than 2 weeks, or we start to see thickening and sclerosis of the cortical borders, then we know we do have a chronic rhinosinusitis. This one we can also see we have dystrophic calcifications within the sinus. Lets us know we have long-standing stagnant mucus, but occasionally that could also let us know we have a fungal infection. We can't tell the difference with our CBCTs between just a dystrophic calcification versus a fungal infection. And these patients really do need to go to ENT to be looked at. This particular case, we have an enlarged ostium or osteomeatal complex, and lets us know we already have a past history of sinus surgery, but the patient does need to go back to their doctor. And occasionally we can see silent sinus syndrome as well. And so with this, we have a chronic obstruction of the sinus that starts to remodel those sinus borders. We get negative intraantral pressure and it starts to kind of suck those borders in. What we can also see is that you have an inferior remodeling of the orbit. And so sometimes the first thing that the patient notices is one eye looks a little bit different or a little bit lower than the other side. And so that's kind of a red flag for us that we have a silent sinus syndrome going on. Definitely want to refer this to ENT. And again, sometimes our sinuses do not fully develop and we can have a hypoplastic maxillary sinus. We occasionally see this. It's a variation of normal. And commonly we'll see it with a mucosal thickening because it affects the entire sinus drainage pathway. If we need to refer it or not really depends on symptoms of the patient. And again, here's another hypoplastic maxillary sinus. You can see how small it is compared to the other side, and you really have an atrophic appearance to the maxilla. We can have a pneumatized sphenoid sinus. Our sinuses tend to like to pneumatize. That's generally what we see, especially in the sphenoid sinus region. And sometimes it pneumatizes so largely it can completely take up the entire sphenoid bone. That is very, very common. This is what it looks like. This is a variation of normal. Now, what's more concerning almost is not finding a sphenoid sinus. Having a genesis of a sphenoid sinus is very, very rare and lets us know we most likely have some type of syndromic entity going on. We can see it, for instance, with Down syndrome cases. Now, of course, we can have, as I said, pneumatization of the sinuses. Or hypoplastic sinus. So we can have quite a lot of variations with our sinuses. They're not always symmetrical. And they're one of the anatomical entities that's not always symmetrical. So ethmoid sinuses up here, they like to pneumatize as well, but they're bounded by the maxillary sinus and the sphenoid sinus. So if they pneumatize, they're going to pneumatize into other sinuses. And so we can see that happening here. This is our infraorbital ethmoid cells or pneumatized ethmoid cells. This is also known as Haller air cells. And when we see it pneumatizing back in the sphenoid region, this is our sphenoethmoidal air cells or our anode air cells. And occasionally this can affect the optic nerve if we have sinus disease, or if ENT needs to go in and do surgery. It's important to identify this because the optic nerve could be at risk when entering in. Okay. We can also have mucus retention phenomenon as well. And this is basically just the lining of the sinus kind of blows up like a balloon. We see it more common in fall and spring with seasonal allergies. Really don't have to do anything about this, again, unless you're going to do a sinus lift and bone graft. Occasionally, we can have a mucocele. Again, if that ostium or the osteometal complex is blocked, the sinus can start to enlarge and act like a pathological cavity. And we see that here with starting to see some expansion and displacement of cortical borders. So that lets us know we have something more serious going on. And we need to go ahead and refer this to ENT to be evaluated. We can see various things in the sinus, such as antroliths, which are basically just little stones in the sinus. This is usually as a result of stagnant mucus. We get some type of mineralization, but we can also have anitis, such as a root tip. So here we have a root tip in the sinus, and of course we have an incredible mucosal thickening bilaterally. So we'll probably need to go ahead and refer that to ENT. Here we have dental material, I should say, probably endodontic material, that is working its way out of the sinus. So the cilia of the sinus work beautifully to remove as many entities as they can out of the sinus. And so here we can see that eventually the dental material will be removed out through the drainage pathways and discarded or swallowed. This was a case of an implant that had failed, and guess what? Our radiology showed where it was. So we can see that it is attached to the anterior and aspect of the sinus and the lateral cortical border of the nasal fossa. It has osseointegrated. So we know the majority of these will osseointegrate wherever they're at. And so this is going to stay there. Really no treatment for this because removing it would cause an incredible bony defect for the patient. We can also see various hyperdensities. This is actually an osteoma. So some heterogeneous, dense, mixed density tissues. They're usually continuous with the cortical bone or attached to the cortical bone. They do like the paranasal sinuses, so it's not uncommon to see an osteum within, or osteoma, I should say, within the ethmoid sinus region. We really don't do anything about these. It's really more of a hamartoma, and it's not going to really affect the patient. Now, if it's affecting, very, very rarely, if it's affecting any type of anatomical tissues, then we might have to consider going in. But usually, we don't do anything about these. All right. So let's quickly talk about the airway space as well. People are very concerned about the airway space. With this, we can see, for instance, just starting at the nasal cavity, we do have some variations in the fluid flow throughout the body. And so it might look like one turbinate is larger than another. If you were to reimage this patient later, you'll see the opposite. The other turbinate will look larger than the other. So this is our normal diurnal variation, how the fluid flows throughout our day. So this is considered a variation of normal and nothing to worry about. It's also very common to see deviated nasal septums. Here we have a deviated nasal septum and nasal spur. And it does let us know that we may have a decrease in the airflow on the affected side. You can also see various polypoid masses, and these definitely need to be referred to ENT. We can't differentiate the soft tissues with Cummings CT. It does look like we are missing some cortical borders, which should alarm us that we have something going on. We can also see various variations of normal, such as concha bullosa, which is pneumatization of the middle turbinate. Again, really don't need to do anything, but occasionally some people will state that it does narrow the middle meatus and may cause some type of sinusitis or play some part in that. We can go ahead and segment out the airway space. We can look at a limited airway space. If the cross-sectional area is lower than 100 millimeters square, we may go ahead and tell the patient we have a limited airway space. We are not diagnosing obstructive sleep apnea. However, we are able to tell the patient you have a limited airway space, which opens us up to a conversation with that individual to see if maybe they also have symptoms and will need to be referred for a sleep study. Now we can see motion. So if the patient is swallowing, we have a nice arc to the soft palate. And of course, that is going to affect the airway measurements that we will get with a Cummings CT. Also, if the tongue is posteriorly displaced, that's obviously going to push the soft tissues back and affect that segmentation and our accuracy of measurements within the airway space for a patient in the standing or seated position. And of course, we know that the various skeletal classifications do make a difference as far as the enlargement of that airway space for the patient, as well as the increased risk for obstructive sleep apnea. We can see enlarged tonsils as well, so we want to rule out an actual obstruction such as enlarged tonsils. Um, we can see, of course, enlarged adenoids and palatine tonsils, just as I show you, but we can also see enlarged lingual tonsils. And if a patient has had their adenoids and palatine tonsils removed, we might see a compensatory enlargement of the lingual tonsils. And so that is something to watch out for. And occasionally, again, we can see a soft tissue mass back in this region, which will require a referral to ENT and additional imaging as well. All right, briefly, I'm going to go through soft tissues because we are short on time. We do see a lot of calcifications within the soft tissue regions, such as tonsillis, sialis, calcified superior corneal of the thyroid, as well as calcified lymph nodes. And this particular patient was lucky enough to have all of those. So sometimes you win the lottery. But we really want to focus in our calcified carotid atheromas because we do see those. These are going to be at the C3, C4 level. So knowing what level you're at is very, very important with cone beam CT. It's important that you realize they're at the C3, C4 level or around that particular region. And these are calcifications within the carotid arteries that are about at the bifurcation of that common carotid. And of course, this does predispose our patient to an increased risk of stroke. We know we're only seeing the calcified plaques. We're not seeing the uncalcified plaques. And so we know that our stenosis is going to be much more than what we're even seeing on our scans. And so for that reason, if this is a patient that doesn't realize they have this, they're not currently being treated for hypertension, or maybe their doctor doesn't know the degree of calcification they have, this needs to be referred to their primary physician. And we'd like for them to undergo a Doppler ultrasound to be able to look at the degree of stenosis of the artery on that particular side. If it's greater than 50% stenosis, they usually will go ahead and do something interventionally. If it's less than that, they might tell Mrs. Jones that she needs to go on medications or maybe diet and exercise. But in any case, it's a huge benefit to your patient to know that this is going on. And we can see vascular calcifications in other areas. This is the intracranial carotid arteries. Now, surprisingly, in this particular area, it's not associated with the risk of stroke because these calcifications are actually within the walls. They're lining the walls of the carotid artery. So it tells us, yes, we do have arteriosclerosis, but it doesn't increase the risk of stroke like we see with the calcified carotid atheromas in the neck. And of course, we can also have calcifications within the vertebral arteries. And again, we have that same arcuate appearance in our axial sections. Looks more like train tracks in our coronal sections. Now, in the region of the vertebral artery, this does increase the patient's risk of stroke, just like with the ones we saw in the neck. And so it's important to point these out and refer the patient to the primary care physician if we see them and the patient's not aware or not being treated for hypertension. All right, so in summary, we can see that while we do see a number of findings, we may not always have to do something interventionally. About 30% of those, though, will require some type of follow-up, monitoring, additional imaging, other diagnostic tests or treatment. And evaluation of the data really serves the patient and protects the clinician. So every CBCT should be looked at. Every volume should be evaluated in entirety. If you're ever in doubt, you can always refer to an oral maxillofacial radiologist. We're very happy to help. And I just want to thank you so very much for your time. And here, of course, we see the incidental finger within our imaging.